All right, diving in today, folks. We're tackling diabetic ketoacidosis, DKA treatment.
Yeah, DKA.
And we've gotten, honestly, a ton of really in-depth medical info from you guys on this one. So our mission today is to kind of sift through all of that and really figure out, like, what are the key takeaways? What really matters when you're actually managing DKA?
Absolutely. And think of this as your, guided tour through the latest and greatest in DKA.
Okay.
We're going to break down how insulin interacts with all those other hormones that try to counteract it.
Right.
We'll explore that ongoing debate about what's the best IV fluid to use.
Saline versus...
Exactly.
Yeah.
Saline versus balanced crystalloids. We'll unpack how to manage those tricky electrolyte problems, especially potassium.
Yeah, potassium.
We'll compare guidelines from different organizations, like the ADA versus others, see if they agree or not.
Right.
And finally, we'll figure out when's the best time to switch gears in DKA treatment, when to step down insulin, how to prevent complications, and what to think about for long-term care after someone leaves the hospital.
Okay, so big picture stuff, but really practical too.
Totally. And to get there, we've gone through everything: systematic reviews, meta-analyses, clinical guidelines, the whole shebang, to bring you this focused deep dive.
Awesome. I love it.
Yeah.
So let's start, I guess, with the very heart of what goes wrong in DKA.
Okay.
It's that messed up hormone balance rate.
Right.
What's the fundamental problem with insulin and these so-called counter-regulatory hormones?
You know, what's really interesting is that DKA really boils down to this massive hormonal miscommunication in the body.
Oh, interesting.
On one hand, you've got either a really severe lack of insulin, or maybe insulin just isn't doing its job properly for some reason. And at the same time, the hormones that usually try to balance out insulins affects things like glucagon, cortisol, growth hormone, and those adrenaline-like catecholamines. They all go into overdrive. It's like a double whammy that sets the stage for all the metabolic chaos we see in DKA.
Okay, so insulin's low and all these other hormones are surging.
Yeah.
What does that actually do to the body, on a metabolic level? What are the tangible effects?
Right. Well, if we think about the core processes that keep our bodies running smoothly, this whole hormonal seesaw throws everything off. The liver gets a signal to crank out way more glucose than it normally would. It does this through two main mechanisms. First, by making brand new glucose from scratch, which is called gluconeogenesis.
Okay.
And second, by breaking down its stored form of glucose called glycogen, a process known as glycogenolysis.
Wow.
So that's why blood sugar levels go through the roof in DKA.
Makes sense.
But at the same time, the body's like, okay, we need energy, but insulin's not letting us use glucose properly. So it starts breaking down fat like crazy into these things called free fatty acids. This process is known as lipolysis, and it's the body's backup plan for getting energy.
So those free fatty acids are like the raw material for the ketones that are the hallmark of DKA, right?
Exactly. The liver takes those free fatty acids and processes them into ketone bodies.
Mm-hmm.
There are three main types: acetone, acetoacetate. And the one we usually see the most of in the blood is 3-beta-hydroxybutyrate. Now, as these ketones build up, they overwhelm the body's natural buffering systems, and that's what leads to the really dangerous metabolic acidosis that defines DKA. It's a really striking example of how crucial insulin is, because even if you take glucagon out of the picture, like in someone who's had their pancreas removed, severe insulin deficiency all by itself can still trigger DKA.
That really illustrates how this hormonal imbalance just spirals out of control. So clinically, it seems like the most obvious takeaway is, we've got to restore insulin to stop this whole cascade of events.
Absolutely. And that actually leads into a really important discussion about the best ways to deliver that insulin. But you're spot on. Insulin therapy is the absolute cornerstone of DKA management. Now let's shift gears a bit and talk about another super important part of initial DKA treatment: fluid resuscitation. Seems like choosing the right fluid might not be as simple as it used to be.
Yeah, that's a great point. I mean, for the longest time, 0.9% saline was kind of like the default.
Right.
But now there's all this buzz about balanced crystalloid solutions.
Right.
Or BES, as we'll call them. What's the main argument for using BES over regular saline?
Well, there's this growing body of evidence suggesting that BES might actually help resolve DKA faster.
Oh, interesting.
There was this 2022 systematic review and meta-analysis by Katahay and their team, and they found a statistically significant trend towards faster DKA resolution with BES compared to isotonic saline. They calculate a hazard ratio of 1.46.
Okay, so what does that hazard ratio really tell us, practically speaking?
Yeah, I know. Those numbers can sound a little technical.
Right.
But basically, what that 1.46 suggests is that if you took a group of patients getting balanced crystalloids, they recovered from DKA noticeably faster, about 46% faster, on average, than those getting saline.
Wow, that's a pretty big difference.
It is.
So what is it about BES that might be giving it this edge?
The key difference comes down to their electrolyte composition. BES are designed to more closely resemble the electrolyte balance in our blood plasma compared to 0.9% saline.
Okay.
Saline has a much higher concentration of chloride, and when you give large amounts of saline, it can sometimes lead to something called hyperchloremic metabolic acidosis.
Oh, right.
It's basically like adding another layer of acid imbalance on top of the acidosis that's already happening in DKA, and this could potentially affect kidney function too. Because BES is more similar to our own plasma, the idea is it's less likely to cause this extra problem.
Okay, so BES sounds like it might be the better choice in a lot of cases.
Yeah.
But why is saline still so widely used? I mean, some major guidelines even recommend it as the first-line fluid.
This is where it gets really interesting because it highlights how complicated it can be to translate research into real-world practice.
Right.
The 2022 guideline from the Joint British Diabetes Societies, the JBDS, they actually recommend more 0.9% sodium chloride as the go-to fluid for initial resuscitation, at least, in a general medical ward setting.
Okay.
One of their main reasons is that it's commercially available pre-mixed with potassium chloride.
Ah, so it's a practical consideration.
Exactly.
Yeah.
This addresses some important patient safety recommendations about giving potassium, which, as we'll get into, is super crucial in DKA management.
Yeah, that makes a lot of sense from a logistics and safety standpoint.
Totally.
But what about head-to-head clinical trials? Have those shown a clear benefit of one fluid over the other?
Right. So the JBDS guideline actually mentions a couple of randomized trials that directly compared 0.9% saline with Hartmann solution, a common type of balanced crystalloid. Interestingly, these trials didn't show that one fluid was clearly better than the other in terms of overall outcomes, like how long people stayed in the hospital or whether they had serious complications. But there was this post hoc analysis, and for our listeners, post hoc just means an analysis done after the original study was finished, often to look for patterns they didn't expect of some emergency room trials. And it kind of hinted that balanced crystalloids might lead to faster DKA resolution in that specific setting.
So the evidence is kind of mixed, with some signals pointing towards BES,
Yeah.
but not a total slam dunk.
Right.
What are some specific concerns people have raised about using saline in DKA?
Well, as we mentioned, the main worry is that higher chloride content.
Yeah.
Cadaha's review actually talked about how this extra chloride could worsen the metabolic acidosis that's already there in DKA, and there's this theoretical risk that it might even contribute to acute kidney injury, which could mean a longer hospital stay.
Okay.
However, it is important to note that the Van Zyl study, which was part of Cadaha's review, didn't find a significant jump in serum chloride levels right after resuscitation with saline.
Interesting. So it's not a completely settled issue.
Huh.
Have there been any big recent studies that could help clear this up?
There was this big study in 2022 by Finfer and colleagues, which looked at critically ill adults in general, not just DKA patients.
Right.
They compared a specific balanced multi-electrolyte solution called Plasmalite 148 with saline.
Okay.
And in the overall study group, they didn't find a statistically significant difference in 90-day mortality or the rate of acute kidney injury. However, a newer meta-analysis that included the results of this Finfer study did suggest that maybe, just maybe, balanced salt solutions could reduce mortality in critically ill adults.
Okay.
But they also pointed out that this possible benefit might depend on the specific subgroup of patients.
So some groups of really sick patients might benefit more from balanced crystalloids than others.
That's what seems to be emerging from the research in critical care. And if we zoom in specifically on DKA, there's a 2020 study by Self and their team, which was a subgroup analysis of two bigger randomized trials. They found that balanced crystalloids actually did lead to faster resolution of DKA, a median of 13 hours versus almost 17 hours with saline. They also saw that people on balanced crystalloids could stop their insulin infusions sooner. This is pretty compelling evidence directly related to DKA.
Right. But Cadaha's review did point out some limitations with the research.
Oh,
already.
absolutely. They mentioned that a lot of the studies they looked at had an open label design, which means the doctors knew which fluid each patient was getting.
Right.
And that could potentially bias the results.
Right, because they might unconsciously treat patients differently.
Exactly. So they rated the overall quality of evidence for faster DKA resolution with BES as moderate, according to the grade criteria. This rating reflected the risk of bias from the open label design and some statistical uncertainty in the findings. But the fact that the results were pretty consistent across different studies did add some weight to the overall conclusion. So while the data leans towards BES being better for DKA resolution, having more high-quality studies that are blinded would definitely give us more confidence.
It sounds like choosing the right fluid for DKA is a pretty complex decision with evolving evidence. Doctors really need to weigh the potential benefits of each fluid, consider practical factors, and be aware of the limitations of the current research. Okay, let's move on to another crucial part of DKA management, and that's dealing with electrolyte imbalances. Potassium in particular can be really tricky.
Oh, absolutely. Potassium levels can swing wildly during DKA treatment, and both high and low potassium can be very dangerous. What's interesting is that when people first present with DKA, it's actually pretty common to see mild to moderate hyperkalemia. That just means elevated potassium levels in the blood.
Okay, so why is potassium often high right at the beginning of DKA?
There are a few reasons for that. First, the super high blood sugar levels create this osmotic pressure in the blood, pulling water out of the cells. And as water moves out, potassium tends to follow along. Second, the breakdown of proteins, called proteolysis, releases intracellular potassium into the bloodstream. And third, the lack of insulin prevents potassium from moving back into the cells where it belongs. The JBDS guideline actually cites a UK national survey that found an average admission potassium level of 4.8 millimoles per liter in DKA patients. That's on the higher end of normal.
So if potassium tends to be high initially, how do we manage that right at the start of treatment?
The general rule is that if the initial potassium level is above 5.5 millimoles per liter, you usually shouldn't add any potassium to the first bags of IV fluids.
Okay.
This is mainly because people with DKA are often quite dehydrated, which can put a strain on their kidneys.
Right.
Adding extra potassium when their kidneys might not be working at their best could make the potassium level go even higher, which could be dangerous.
Okay, so we hold back on the potassium at first if the level is high. But we know that potassium often drops as we treat the DKA with insulin.
So right.
Why does that happen and how do we manage that?
So you're absolutely correct. Hypokalemia or low potassium is a big concern as treatment progresses. When you start giving insulin, correct the acidosis, and replace fluids, potassium starts shifting back into the cells. This, combined with ongoing potassium loss in the urine as kidney function improves, can cause the potassium levels in the blood to fall, sometimes pretty rapidly. So the general rule is to start replacing potassium once the level drops below 5.3 milliequivalents per liter. But here's the catch. You only do this if the patient is making enough urine.
Right.
We're talking at least 50 milliliters per hour. This tells us that the kidneys are working well enough to handle the extra potassium.
Makes sense. So once the potassium starts dropping,
Yeah.
how much do we typically add to the IV fluids?
The usual recommendation is to add somewhere between 20 to 30 milliequivalents of potassium to each liter of IV fluid.
Okay.
But this needs to be carefully adjusted based on the individual patient's potassium levels and how they're responding to treatment. You need to monitor those potassium levels really closely. It's a bit of a balancing act because both very low and very high potassium can be life-threatening during DKA management.
Right. So monitoring and individualizing the treatment are key.
Absolutely.
Okay. Let's shift gears a little bit and compare different clinical guidelines for overall DKA management. Specifically, we'll look at the ADA, the American Diabetes Association, and compare their recommendations to other guidelines, like the JBDS we talked about earlier.
Okay.
Are there any big differences in how they approach fluid choice, infusion rates, or monitoring?
Yeah, there are some interesting differences. They even differ a bit in how they define the severity of DKA. The ADA criteria actually use the anion gap as part of their classification system for DKA severity, mild, moderate, severe,
Okay.
while the JBDS criteria mainly focus on blood glucose, ketone levels, and either bicarbonate or pH.
Right. So just a slightly different way of looking at the same problem.
Exactly. And just for our listeners who might be curious, the anion gap is calculated using the levels of sodium, potassium, chloride, and bicarbonate in the blood.
Okay.
But both systems are ultimately trying to gauge how severe the metabolic disturbance is.
Got it. So what about initial fluid resuscitation? Do the guidelines agree on that?
Well, both the ADA and the JBDS agree that starting 5e fluids early and aggressively is absolutely essential in DKA.
Okay.
But the JBDS guideline is a bit more detailed and specific about exactly how to do it, especially in those first few hours.
Yeah.
They recommend giving a bolus of 500 milliliters of 0.9% sodium chloride pretty quickly, over 10 to 15 minutes.
Wow, that's fast.
It is. And they say to repeat that bolus if the patient's systolic blood pressure stays below 90. Once their blood pressure gets above that, they recommend continuing with 1 liter of 0.9% sodium chloride over the next hour. They also say that you'll probably need to start adding potassium to that second liter, assuming the initial potassium wasn't too high.
Makes sense.
Now, if the patient comes in with a systolic blood pressure that's already 90 or above, the JBDS says to go straight to that 1 liter of saline over the first hour.
Okay, so that's a pretty structured fluid plan.
It is.
What about monitoring? How often do they recommend checking on the patient, and what specifically are they looking for?
The JBDS is all about frequent monitoring, especially in the beginning. They recommend checking vital signs every hour using something called the NNWS2 scoring system.
Oh.
This system helps figure out which patients might be getting worse. They also stress keeping a very close eye on fluid balance, making sure the patient is peeing out at least 0.5 milliliters per kilogram of body weight each hour. And they want blood ketones and capillary glucose checked every hour too.
Wow, that's a lot of monitoring.
It is.
Does the ADA have similarly detailed recommendations?
The ADA also emphasizes frequent monitoring of vital signs, glucose, ketones, and electrolytes, but the JBDS is definitely more granular, especially in that initial resuscitation phase.
Okay.
Both guidelines agree on the big picture, correcting the high blood sugar, the acidosis, and the ketones, fixing electrolyte imbalances, and finding and treating whatever triggered the DKA in the first place.
Right.
The JBDS also really stresses getting a diabetes specialist involved early on. They actually cite evidence that early specialist input can shorten hospital stays and make things safer for the patient.
Okay, that makes sense.
Yeah.
So how does the GBAS define DKA resolution? Like, when do they say, okay, the DKA is resolved?
Their specific criteria are a blood ketone level below 0.6 millimoles per liter and a venous pH above 7.3.
Okay.
And this is important. They specifically say not to rely only on the bicarbonate level at this point.
Interesting. Why is that?
Because if you keep giving 0.9% saline, it can actually cause a hyperchloremic acidosis, which would lower the bicarbonate level even if the ketoacidosis itself is gone.
Ah, I see. So the fluid you choose can actually affect how you interpret the lab results.
Precisely. It's a really important nuance.
Yeah. Okay, so once the DKA is starting to resolve, what are the key things to think about when transitioning the treatment? When do we start thinking about moving from IV insulin and fluids to more routine diabetes care?
The JBDS guideline says that in most people with DKA, the ketones and the acidosis should clear up within about 24 hours of starting treatment. Once the blood sugar consistently gets below 14 millimoles per liter, they recommend thinking about lowering the IV insulin infusion rate. They usually suggest cutting it in half, from 0.1 units per kilogram per hour down to 0.05 units per kilogram per hour. This updated recommendation aims to minimize the chances of hypoglycemia, low blood sugar, during the transition.
Okay, makes sense. So what are the specific things that need to be in place before a patient can switch to subcutaneous insulin injections?
The main things are that the person is getting better clinically, they're able to eat and drink normally without feeling sick, and their lab values, specifically their glucose, ketones, and pH, are pretty much back to normal.
Okay.
But here's a really important point. The subcutaneous insulin, ideally a fast-acting insulin given right before or with a meal, should be started about 30 to 60 minutes before stopping the IV insulin.
Okay.
This overlap is super important to prevent the blood sugar from spiking back up as the IV insulin wears off. The JBDS actually references a 2012 study by Asia and colleagues that supports this timing.
Okay, so that overlap is key. What about patients who are newly diagnosed with diabetes and haven't ever taken insulin before? How do you figure out their initial subcutaneous insulin dose?
So for those folks, the JBDS guideline recommends an initial total daily dose of subcutaneous insulin somewhere between 0.5 to 0.8 units per kilogram of body weight.
Okay.
This would be split up into doses given with meals and maybe a basal dose too, depending on the specific situation and the hospital's protocol.
Right.
It's really individualized.
Okay, makes sense. What if a patient's ketones have cleared, their acidosis is gone, but they're still having trouble eating or drinking enough?
In that case, the JBDS recommends continuing the IV fluids to keep them hydrated.
Okay.
They also suggest switching to a variable rate intravenous insulin infusion, often called a VRI3.
Okay.
This basically allows you to adjust the insulin dose more flexibly based on frequent blood sugar checks until the patient can eat and drink better. It's also super important to remember that throughout this whole process, you need to keep working on identifying and treating whatever caused the DKA in the first place.
Right.
Things like infections or missed insulin doses.
Right. Address the root cause. Okay, let's look beyond the acute phase of DKA. What are some important things to consider for long-term management and preventing future episodes?
This is where educating patients, addressing any lifestyle factors they can change, and making sure they have good ongoing diabetes care are super important. There was this 2016 review by Nineway and Katapchi that showed a strong link between illicit drug use and repeated episodes of DKA.
Wow.
So it's crucial to support people who are struggling with substance use. For people with type 2 diabetes who develop DKA, things like losing weight if they need to and taking their diabetes medications as prescribed can make a huge difference in preventing future episodes.
Okay.
It's also important to remember that sometimes DKA is how someone first finds out they have diabetes, whether it's type 1 or type 2. So education about diabetes and developing a long-term management plan are crucial in those cases.
Right. This has been a really in-depth and insightful look at DKA treatment. To wrap things up, what are the key things you think our listeners should take away from this discussion?
The main takeaways, I'd say, are first, understanding how DKA develops. It's basically a critical imbalance between insulin and those counter-regulatory hormones. This makes prompt insulin therapy absolutely essential.
Right.
Second, there's still debate about the best IV fluids for resuscitation. There's evidence that balanced crystalloids might resolve DKA faster, but 0.9% saline is still commonly recommended, in part because of practical considerations and safety concerns related to potassium management. Third, carefully managing electrolyte abnormalities, especially potassium, is crucial because levels can change so quickly during treatment. Fourth, clinical guidelines, like those from the ADA and the JBDS, offer valuable frameworks for DKA management, but they do have some differences in their specific recommendations. And finally, switching from IV to subcutaneous insulin requires careful timing to prevent complications.
Right.
And long-term management is all about addressing underlying risk factors and optimizing diabetes care to prevent future DKA episodes.
And it's so important to remember that these are complex decisions that should always be tailored to each individual patient,
Absolutely.
taking into account their specific situation, the resources available, and any relevant local guidelines.
Exactly. And that brings us to a final thought for you, our listener. Think about how even subtle differences in those IV fluids and the nuances of monitoring can really impact how well patients with DKA recover. Maybe this will inspire you to explore the research and the latest recommendations in this critical area of medicine. Thanks for joining us on this deep dive.
Thanks for listening, everybody.